Okay, so now we're going to have Dr. Curry, also known as Dr. Mommy or Dr. Muffins, testifying. She's back. Remember, Dr. Curry is the one who already examined Amber Heard, so she was able to diagnose her properly, unlike Dr. Spiegel. Also, if you are new to my channel, please make sure to hit the like button, subscribe to the channel. What are you waiting for? You'll get videos, you'll get notifications every time my videos come up. So I would really appreciate it. And if you can, share the videos, that helps. And comment below, let me know if you like what I'm doing and if you want to see more of it. So for people who are not aware, for the first couple weeks of this trial, I was attending in person. I live in Northern Virginia, in Fairfax County, and I have met this gentleman right here, Johnny Depp's. He's one of Johnny Depp's bodyguards. Sean Betts is sitting next to him. I didn't personally talk to Sean Betts, but this guy is a really nice guy.
Good morning.
There's also this guy here, this officer. I call him Officer Sexy. He's super cute. He looks cuter in person. I swear.
Curry, Dr. Shannon Curry.
That's fine. Maybe
Dr. Curry's looking good today. Let's go. Oh, Amber's sneezing over this.
Good morning, Dr. Curry.
She does not like her.
Can you remind the jury who you are and what you do?
Sure. I'm Dr. Sharron Curry. I'm a clinical and forensic psychologist, and I'm here today to rebut the testimony that was provided by Dr. Hughes.
Yes!
Which of the opinions rendered by Dr. Hughes do you intend to rebut?
So generally speaking, there are three main categories that I'd like to talk about today. So the first is that Dr. Hughes misrepresented the tests and the results that she utilized in her evaluation. Yep. She misrepresented my testing and the results that I obtained in my evaluation. And she communicated in a manner, provided testimony in a manner that presented essentially her own opinions and the self-report of Ms. Heard as facts.
Amazing.
Okay, the first category you talked about was a misrepresentation of her own test methods and results. What do you mean by that?
So Dr. Hughes she stated that she administered 12 tests. In actuality, she used 8 checklists.
Oh my God.
About half of those were symptom checklists. The other half were checklists about experiences that people can have with domestic violence. And those are not appropriate for forensic settings. They are easily exploited.
Oh my God.
Other issues that you intend to address relative to misrepresentation of own results?
Yes, so in addition to using these checklist measures, which are easily exploited in a forensic context, they're developed for research or treatment only. She also stated that these checklists revealed things that they simply cannot reveal, especially in this context. Let's see. She also misrepresented clear indications on several of the objective measures that she offered. And there were indications visible that Ms. Heard had essentially engaged in what we call response distortion. So clear indications of exaggeration on one of the measures that's specific to PTSD, clear minimization of symptoms, intentional, on another more broad personality and psychopathology-based measure that she gave to Ms. Heard, which she did not acknowledge.
Did you intend to address anything relative to the CAPS-5?
I did. So Dr. Hughes administered the CAPS-5 about 10 days after I did, almost 2 years after she initially tested Ms. Heard. And she did not administer the test appropriately. So she left major components blank. She didn't apply the scoring rules that are clearly outlined with the test. And yet she diagnosed Ms. Heard with PTSD based on that assessment.
What about Dr. Hughes's use of the personality assessment inventory?
So of the tests that Dr. Hughes administered, 2 would be considered, of those 12, 2 would be considered what we call forensically relevant instruments, meaning that they're objective enough and they provide us with some information about how the examinee approached the test, that it would be appropriate for this setting where the examinee is going to have a natural incentive to present themselves in a way that benefits the outcome of their case. Now, on the PAI, there were clear indications that Ms. Heard was responding and obtained scores in a manner that's consistent with individuals who have a personality disorder. And there was also an indication that several scales, we call this a configuration. So you might have one main scale that you notice is elevated, then you look for additional subscale information to get additional information on what could be elevating that scale. And there was a configuration that showed that even though Ms. Heard had moderately elevated one of the scales that can be associated with trauma, that elevation is better explained by childhood or distant traumatic experiences like the complex trauma Ms. Heard reported experiencing growing up.
Wow.
Okay. You said that Dr. Hughes utilized checklists that are not appropriate for forensic analysis. Can you explain that?
Yes. So, as I said, in any sort of forensic context, whether it's a civil or a criminal matter, a person who's being evaluated is going to have major incentive to present in a way that benefits the outcome of their case. So you always approach the examination, I believe Dr. Hughes said, with a healthy dose of skepticism.
Yes.
But that alone is not enough. We have to operationalize that. So we actually have to administer very comprehensive objective tests that either control for attempts to manipulate the test results or reveal attempts to manipulate the test results, so that we're not just blindly accepting the results.
That's right.
Or the self-report of the examinee.
How many tests were administered by Dr. Hughes?
She said that she administered 12 tests.
How many of them were appropriate for forensic physical examination?
So the trauma symptom inventory is appropriate. It's an objective measure, and it does have 2 primary scales that look at how the person approached the test. The personality assessment inventory is an excellent test. It is a broadband measure, meaning that it captures not only symptoms of mental illness, but also general personality traits. That also gives us pretty detailed scales similar to that one test I administered, the MMPI, that tells us a lot of nuanced information about the way the person approached the test. She also administered a malingering screen that can be very, very useful, but not in this context.
Oof.
So it's called the Miller Forensic Assessment Symptom Test. It's a brief set of questions that you ask the examinee, and it's been shown by research to be extremely effective at identifying an examinee's attempts to fake a severe mental illness or psychosis. And psychosis is when somebody loses complete connection with reality. It's excellent for that purpose. It's actually been shown in the research to not be effective at all for identifying a respondent's attempts to fake PTSD, anxiety, or mood disorders. Wow. The questions are just too odd for somebody who has the wherewithal to be trying to have PTSD to endorse. They see through it. So she used that. That's a fine test, but not appropriate for this context.
Of the various tests that she administered, how many were these checklists?
8 of them.
All right. And what are you talking about specifically?
Okay. So I had mentioned that there were 2 main categories of checklists she used. The first is the symptom checklists. Those included the Beck Depression Inventory. It's a brief inventory of items that essentially show all of the symptoms of depression that a person might have, and you rate which level of severity you have for each question. She also gave the Beck Anxiety Inventory, very similar, but just with questions about anxiety. She gave the Mood Disorder Questionnaire, which is a very brief, again, checklist. It shows symptoms of bipolar disorder. Bipolar disorder is a mood disorder where you might have an extended manic episode and then a very extended depressive episode. And then she gave the post-traumatic stress disorder checklist, and that is a screening instrument only. It contains every single symptom of PTSD. So there's a secondary danger here too. When you think about it, given that PTSD is the most frequently feigned and claimed diagnosis in civil courts, if you're handing somebody a checklist that lists every single symptom of PTSD, you're essentially teaching them all the little nuances that we're looking for to give that diagnosis.
Oh my God.
So she gave that to Ms. Hurd. Ms. Hurd endorsed most of the items, and Dr. Hughes diagnosed her with PTSD and substantiated that opinion by Ms. Hurd's checking those items on the PCL-5.
So she could fake it. She was helping her fake it, basically.
Were there another group of checklists that Dr. Hughes used?
Wow.
Yes, so she also, and I forgot one on the last because I don't think of it as one, but previously I'd explained, and I do not expect you to remember, it's called the Life Events Checklist, which is just an inventory of experiences a person may have gone through that are traumatic. Dr. Hughes also used that, and that's appropriate to use before the clinician-administered PTSD scale, the gold standard, CAPS-5. However, she administered this long ago before she gave the CAPS-5. Now that going on to the second group, there were 3 checklists that she gave that are specific to abuse. And the first she gave, the Danger Assessment Scale, was actually developed for use by nursing staff in an emergency room setting, specifically for female victims of intimate partner violence. The purpose of this is important because our forensic ethics, our psychology ethics, talk a lot about relevance. Is
Yes.
the test relevant to the purpose? And the Danger Assessment Scale, its initial purpose is completely different. This was developed to show high risk factors for dangerousness and pretty much to help a female who is in an extremely abusive partnership, who is in the emergency room with extreme injuries, to stop rationalizing, because if she has to check off all the things that have happened that year that have been dangerous, does he own a gun, has he, I won't go into all of them, but the more she checks off, the more likely it is that she might realize that she is in imminent danger, and then accept resources offered by the hospital and social work to protect her. That was the purpose of this scale. It was never intended to be used as a retrospective measure
Exactly.
to look back in time and find out whether abuse was occurring based on one person's report years later in a litigation. She also gave the Conflict Tactics Scale, revised, the second edition. Similarly, this scale was developed for research purposes, to research family violence. Again, there is no control for exaggeration or minimizing. It was just given to research participants anonymously so that we could get data on the prevalence of abuse and how abusive dynamics work. And on that, there's 39 questions where the respondent indicates essentially certain abusive behaviors they may have engaged in, and then 39 where they indicate behaviors their partner might have engaged in. And obviously, you can understand that in a forensic setting, the respondent is likely to put a very minimal amount of behaviors they engaged in.
Of course.
And then extremely increase the number of behaviors their partner might have.
Exactly.
And then lastly, let's see, the abusive behaviors observation checklist was the third checklist she gave. This one has not, there's no known research even on its effectiveness for what it was developed. It's a theoretical, very brief checklist that was meant to be used for therapy, where an individual who had experienced domestic violence could essentially read through some of the behaviors that constitute violence that they might not have been aware of. And if those behaviors applied to them, or if some of those coping strategies were ones they utilized, they would check that off. And then they have a way to talk about it because now it's been put to words. Again, this is similarly problematic if you're in a civil litigation, the person's motivated to have their results be consistent with a claim or an allegation of intimate partner violence and an allegation that they've been severely harmed, then they could simply just check off more. And not only that, but checklists like this one specifically give a lot of nuanced information about what clinicians might be looking for when they're assessing whether violence was present or whether the person's self-report is consistent with a genuine self-report of having been victimized. They're given all that information that we might be looking for.
Can you talk specifically about Dr. Hughes's use of the, I think you called it the PCL-5?
Yes. So the PCL-5 is the post-traumatic stress disorder checklist. This is different, not to be confused with the CAPS-5, which I've talked about previously as being the gold standard. The PCL-5 was developed by the National Center of PTSD. It's intended for treatment. So if I were, for instance, working with a service member who I know had been in combat, I would probably give this as a standard with my intake. Before we do the diagnostic interview, it kind of gives me a read on how somebody who's there for treatment, who we assume can be taken at their word, because if they give us correct information, they're going to get an appropriate treatment. And if they give us incorrect, they might not get the treatment they need. So I would give this checklist to them, and then if they recognize some of those symptoms of PTSD, they could check it off. And that would probably indicate to me that I need to then do the next step. If they're checking off more items than not, I would probably decide to administer the clinician-administered PTSD scale, that gold standard interview, to find out more about a diagnosis.
The last thing is what everybody refers to as the CAPS-5?
Yes, the CAPS-5.
All right. What about, well, you talked about forensic use. What do you mean by that?
So when I'm talking about forensic evaluation, that's an evaluation that isn't done for therapy or treatment. It's specifically to assist the fact finder, to assist the judge or the jury in the court by providing information about the psychological status about an individual. And that's an important delineation too. We are not psychologists. I wish we were mind readers. I wish we had a crystal ball and could find out whether intimate partner violence occurred and look back in the past. But it's nothing like that. Really, it's a lot less interesting. We look at data. We have to control for those response biases.
Yes.
And then we also are looking at functioning, which is really the bottom line of the assessment. Did the person have a change in functioning from before the alleged trauma, or in this case, the alleged IPV, to after? Is there a decline in the way they're going about their lives?
Objection, Your Honor, may we approach?
All right.
Of course. Of course. Elaine is not happy with that. And look, you can see Whitney's here again today. She's, I think, the only family member of Amber Heard's that is here. You can see her sitting there. The DUI guy is in the row behind her. He's not directly behind her, but over to on the left side. I do not see James today, but it's been insane. I mean, the reason I haven't been attending in person anymore is because you have to get there around 10 p.m. at night, the night before. You literally have to stand in line all night now, and there are crazy people that are showing up, people that are, I don't know how to say this without sounding rude, but are not bathing, to put it mildly. There was a crazy woman who tried to tell Johnny that she had his baby or something and that their souls were connected, and literally had to be escorted out by police. You know, so it's just like a madhouse at this point. It's turned into like a circus, and I just don't have the wherewithal to go at 10 o'clock at night, the night before, stand in line all night, and then be lucid enough to pay attention in court the next day. Because, you know, when you're in there in person, guys, these benches that the gallery is sitting in, they're not comfortable. There's no cushions on them. They're wooden, like, pew type benches, so they're not fun to sit in. It's uncomfortable. These are long days. I mean, you're sitting here, and when you're in person taking notes, you cannot take out your cell phone. You have to just sit there and watch this stuff. And it does at times become very boring. you start to fall asleep. I used to have to shake myself to kind of keep myself awake. And because it's being live streamed, I mean, the only benefit to being in the courthouse is being able to look at the jury. I have a pretty good idea of the jury at this point, and what the makeup of the jury is, and I think kind of where they're going at this stage. But the first 2 weeks, I would get there at 7:30, and I'd be able to get a wristband and get in fine. Early on, there were a lot more like professional type people that were there. So they were there to kind of be like independent journalists and to report on the case. I got to meet Darth News, Dr. Soup, a couple YouTubers and stuff like that. And the kinds of people that are showing up now are very different. They're like super fans, people who just want to be on TV and stuff like that. So, okay, we're back.
Dr. Curry, let's look back at some of those domestic violence checklists that you were talking about.
Okay.
And did you see any problem with the use of those?
Yes.
What problems did you see?
Well, Doctor, first of all, they shouldn't be used. So we do have professional standards that require that we utilize instruments that are relevant and appropriate for the particular setting, and that we substantiate our opinions based on data that is reliable from tested, accurate, reliable tests for the purpose. So there's that. It's inconsistent with the ethics. And essentially, they just shouldn't be used. They don't provide us with the robust information that it would be expected in such a high-stakes setting.
Would you have expected Dr. Hughes to comment on the limitations of the checklist she was using?
Yes. So, first of all, Dr. Hughes provided opinions based on these checklists. So she referenced especially the danger assessment scale several times throughout her testimony, stating that Ms. Heard was in a very dangerous situation. We also have an ethical guideline and a professional standard as well that indicate that whenever there is question about the reliability and the validity, and in psychology we use the term validity to talk about accuracy, of any of the methods that we're using to collect data, we clearly communicate not only that there are limitations to our opinions, but we also need to provide the fact finder with information about what the potential implications or impact could actually be. So, for instance, if we use a scale that's idiosyncratic for the purpose, but we would first need to explain why we made that decision to not follow standard procedures. And then we would need to explain the use of this scale might introduce some potential exaggeration of this symptom, and yes, so I'm trying to control for that way, but that was one of the limitations of my opinion. You have to make it very clear. Transparency is really at the center of good science in general.
Exactly.
You talked a little bit about ignoring response distortion. What is response distortion?
Response distortion is a term that speaks generally about an examinee approaching a test and providing answers that are either exaggerated or minimized, but in some way an inaccurate representation of their current mental status or their experience.
What test do you believe that Dr. Hughes failed to acknowledge response distortion on?
So she administered the personality assessment inventory, which is similar to the test I gave the MMPI-2. It's that general broadband measure of psychopathology symptoms and personality traits. It includes several scales that are very good at detecting either exaggeration, minimization, or even trying to claim that you have unusually good qualities. On that test, there were clear indicators that Ms. Heard, very similar to the way she approached my MMPI, engaged in defensiveness. And in fact, there's a function that you can look at. So you have that main scale elevation, we call it positive impression management, was elevated. And then, because we want to make sure that somebody isn't elevating that scale just because they have such well-being, there are additional configurations of scales that you can look at to find out what's going on. And so the Cashel discriminant function is sort of the name of one of these configurations, these equations that are done. And she was highly elevated on that. In fact, that elevation tells you that no, this isn't accidental. This isn't because she's just doing so well in life that she has an extremely, extremely low amount of problems. No, this is an intentional over-reporting, or I'm sorry, an intentional effort to minimize any appearance of having problems.
Now, you may have addressed this, but there was a reference to malingering.
Yes. So what's interesting about Ms. Hurd's approach to different tests is that it seems to be influenced by what we call the face validity of questions on the test. So if a test looks like it's measuring PTSD, you see exaggeration on her validity scales. If the test has less face valid questions, for instance, the personality assessment, which Dr. Hughes administered, the MMPI-2, which I administered, where she can't quite figure out what the questions are asking, they seem really banal in general. On those, you see extreme defensiveness, minimization of any potential pathology, essentially presenting herself as perfect and free of any mental illness or personality disorder. But on the trauma symptom inventory, which Dr. Hughes administered, that was the one that I previously indicated for ease of explanation. When the test results come out for how the person approaches the test, that test itself prints it as a percentage. And there's a really excellent scale for finding out if a person is exaggerating their symptoms of PTSD. It's called the atypical response scale. And the TSI-2 is the revised version of this test, and that scale was improved this time around to really try to be a clean indication of, is this person exaggerating? And it puts quite high questions in the test that are so unusual. They might sound like PTSD, but even the most severe cases of PTSD don't have these symptoms. And so somebody who's intentionally trying to exaggerate PTSD, or possibly unintentionally, but nonetheless who's exaggerating it, is likely to endorse these items even though they're not real PTSD symptoms. Ms. Hurd scored so highly on this that even if there is, although Dr. Hughes correctly said there tends to be a negative skew when people have the high levels of distress that's associated with PTSD, so sometimes people score higher on this even when they do have PTSD. She scored so high that that is effectively ruled out as a possibility.
Wow.
Okay.
Oh my God, what a psycho.
About Dr. Hughes's administration and use of the CAPS-5?
Okay, yes. So Dr. Hughes had diagnosed Ms. Hurd with PTSD back in 2019 when she began testing her. It wasn't till 2 years later, more than 2 years later, 10 days after I administered the CAPS-5 with Ms. Hurd, that Dr. Hughes held an impromptu evaluation session remotely with Ms. Hurd and administered the CAPS-5. She had previously diagnosed PTSD without using what we consider to be the gold standard PTSD diagnostic interview. And again, when we're doing a forensic evaluation, it is an important responsibility, and part of our ethics and professional standards are that we document everything to allow for transparency and full judicial scrutiny. And Dr. Hughes administered incorrectly. She left huge sections, very relevant sections, blank. There's no way to understand why she scored it as high as she did based on the information that's provided. You're essentially supposed to notate the examinee's responses as verbatim as possible to explain your reasoning and implying their scoring procedure. It's a standardized test, and if you don't follow those standard procedures, it's completely invalid. Not only that, but it looks as though Dr. Hughes further invalidated it by trying to show that she had assessed for the childhood trauma impact, and she had said that she went back and asked the childhood question, but you can't do that. If you're assessing for two separate periods of one's life to find out their relatedness to PTSD, you do two separate CAPS interviews, period. You don't create your own question system. That is non-standard administration of the test, and it invalidates it.
Oh my God.
You also mentioned, with respect to the PAI, or the Personality Assessment Inventory,
That's crazy.
that Dr. Hughes failed to mention some elements. What did she fail to mention?
Oh, okay. So on the personality assessment inventory, so first she failed to mention that there were clear indications of response distortion. She also failed to mention that Ms. Hurd scored in her score profile against their main scores. She did elevate a score for the borderline personality disorder sort of section, but that in and of itself would not indicate a diagnosis. However, the configuration of her scores overall is consistent with that, and in fact, it's one of the diagnostic suggestions given by the test itself. And then also, there's a configuration around Ms. Hurd's trauma responses on that particular test, which demonstrates that it is more likely that those symptoms were reported in relation to something in the distant childhood. It's more consistent with childhood chronic abuse than present circumstances or recent circumstances.
Wow.
Okay, I think you said, in addition to the issues with her own testing, Dr. Hughes misrepresented your results.
Damn.
She did.
Can you tell us how?
So what I would say the main issue was that she said that Ms. Hurd obtained a normal profile on my MMPI-2.
All right. How do you disagree with Dr. Hughes relative to the profile?
Okay. So the profile was not normal. So Ms. Hurd already had subtle elevations just by the test by itself as it came out. There were subtle elevations, but they were elevations that if the validity scales hadn't been as elevated as they were, you might have said this person has some traits, but this isn't necessarily at the level of a true pathology. However, Ms. Hurd elevated a scale that essentially is a defensiveness scale on this test. And when you're giving this test, you always are mindful of different norms or groups who may have similar profiles. And there are certain groups of litigants who tend to elevate this scale as well. So I had that in mind. However, Ms. Hurd elevated this so much that it was far beyond the mean for the litigants that are known to have the highest levels of
Holy
this scale,
shit. So
this
she tried to
defensiveness
game
scale.
it.
And when this scale is elevated to the level that it is, you automatically understand that it is very likely that those clinical scales, I keep doing this because I'm seeing it in my head, it looks like sort of an ECT. It's sort of these peaks you see on a graph. And when you see these peaks, and you have this huge peak over here for the defensiveness scale, what you know is that these peaks are artificially, they've been lowered or suppressed based on the respondent being so defensive. They still detected what's likely there for her, but it's not as high as it should be. So you make an adjustment. And the recommendation is that anything at 60 or above, we call it a T-score of 60 or above, is considered significant. Ms. Hurd's were already over 60. Some were quite higher than that. And then you see a very clear profile. And that was how I got that. I had mentioned a 3-6 code type. Now, the test does its own correction also for some of the scores, but not the ones that are her main code type.
Damn.
With the test correction, she had a 1-3-6 code type, which is very similar.
What is a 3-6 code type?
A 3-6 code type is something that has been researched and found to be highly correlated or probabilistic of certain behavioral tendencies and personality traits. And the traits with a 3-6 code type tend to be marked by a lot of externalization of blame, a lot of denial about one's own personal faults, intentional or not intentional, but just extreme denial, hostility that is strongly controlled and suppressed. The person may not even realize how hostile they are, but family members, those closest to them, are very likely to report that they lose their temper, and when they lose their temper, it explodes. We have sort of what we call a cookbook for these code types, which will provide you with all the information that's been researched to be associated with them. And our cookbook actually states that that 3-6 profile specifically tends to be associated with cruel and ruthless behavior, particularly to those who they perceive as less powerful than them and subordinates.
Describe for the jury the review process that you went through relative to the MMPI.
So I conducted a very methodical analysis of the scores. I do this for every test, and I also did it when I was reviewing Dr. Hughes's scores. So what you haven't seen that's in Discovery is that I created a 25-page outline just of her scores with, and it's sort of a table. So I'll put the score, I'll do it in sections so that I can understand different groupings, different research studies, and I start with looking at all the validity scales. So I put in the score, and I'll even color the table to show me if it's kind of in the high zone, moderate zone, or low, and then if it's low, is it a significant low score, or is it just low so it doesn't mean anything? And then in the right side, I put all the research data that I found on this particular scale score. And so I start with the validity scales, the way the person approached the test. Then I go down to essentially, we call these the first factors. So their overall sense of well-being and how well they cope. On this, actually, Ms. Hurd's, she endorsed scores or endorsed items that were the opposite of PTSD. So really saying that she feels free of distress and that she views herself very well. So then I go down to control, self-control, loss of control, coping abilities, and I put in the scores that are associated with that in the research and the test development.
Oh my God.
Then I go down to clinical and personality pathology, and I look at all the scores that are significant there, first with the top level main scores, then with all of the different sub-scores, again, citing the research, the meaning, the level of elevation, and what that means. And then I do comparison with different research groups. So for Ms. Hurd, I did a section that looked at all sorts of different scores that have been implicated with a PTSD presentation to see if any of those were consistent. I can't remember how many there were. I think I put 13 on there, but I could be wrong. But I believe that there was only one that could even be, in some research, is sometimes associated with it, but it was general anxiety, which turned out to be more trait specific. I looked at the scores that are typical of women with IPV. Hers were not consistent at all with those.
Ooh.
I looked at the scores that were consistent with people who are frequently in litigation. Hers actually were very highly correlated with those. That tends to be also consistent with a 3-6 code type, and the reason for that is believed to be that they tend to perceive themselves often as victims who need to avenge wrongs.
Oh. Okay, so we're going to leave it there for now. This video has already gotten pretty long. I'll put up a part 2 with the rest of Dr. Curry's testimony. But this is just unbelievable. What she's essentially saying is that Dr. Hughes helped Amber lie, that she did sort of like an improper testing and things that she kind of knew were not appropriate for this situation. With Amber, like the one that was for imminent harm of somebody that was basically beaten to the point where they're being hospitalized, that was to kind of help them understand that, like, you could die. You are in imminent danger. That's not what's happened with Amber, you know, and so it just seems like that she was basically paid to help Amber present herself as a victim of DV and somebody that has experienced IPV. So that is very disturbing. And just kind of looking at Amber throughout this, as Dr. Curry is testifying, you can see that sort of hostility, that rage. So I will get the next part of Dr. Curry's testimony picking up right here, exactly where we left off, up in a minute. And again, make sure if you haven't yet, please like, the video. That really helps us get up there and beat the algorithm. Subscribe to the channel, leave a comment. Let me know if you enjoy what I'm doing, if there's something more you would like me to do or something that you dislike. Let me know. It all helps me create better content for you guys.